Hello and good evening. Welcome to our migraine masterclass. This is one of a series of events where we bring world experts and local Middle East experts together to bring you migraine and the science of migraine. I'm very happy to welcome everybody who's joined us tonight. Good morning, good evening, good afternoon, wherever you are in the world. We're very happy that you're joining us today. It gives me great pleasure to be moderating this event. My name is Heba Banihani. I'm a pharmacist specializing in migraine. And today our masterclass is going to be on migraine medications from overuse to appropriate use. I would like to thank our sponsor, Pfizer, for their kind sponsorship of these educational programs and everybody that has joined us today. This event is accredited. We will be providing you with your certificate of attendance within 1 week from your attendance. Please stay the whole time, and that will mean that you will be able to get that certificate. Join us also in participation and send your questions to the Q&A that is at the bottom of the panel on your Zoom. And we will be taking your questions. And there's two parts today. The first part is going to be with Dr. Lara Pizzetti, and she will be taking questions after her session. And then our second part is going to be with Dr. Manal Faham, that also will be taking questions at the end of the session. So put your questions in the Q&A, and I will be posing these questions to our speakers at the end of their session. So again, welcome everybody. If you've just joined us tonight, we are joined by Dr. Lara Pizzetti, who is a neurology specialist from Santa Catarina in Brazil. Dr. Lara is someone that I know personally. She's one of the brightest people that I have met, a neurologist that has a lot of experience in managing headaches, is currently one of the brilliant people that is doing the Master of Headache Disorders at the University of Copenhagen. She has a lot of experience in stroke, and she has decided to add to that headache. So it gives me great pleasure to introduce her today. Today's session is going to be on, again, migraine overuse, medication overuse, headache, and how to manage it, and refractory headaches. So again, join me in welcoming Dr. Lara, and I hope that you enjoy this session, and do not forget to put your questions in the Q&A. Dr. Lara, welcome. I think you're muted. I can't hear you. No, I still don't think we can hear you.
What about now?
Yes, absolutely. And we can see you as well. Thank you very much. And again, welcome, Dr. Pizzetti. It's a pleasure to have you. Thank you for joining us tonight.
Thank you so much for this opportunity, for you, for Association of Migraine Disorders, and especially Kylie for this opportunity. I'm going to share with you my screen. Can you see it?
Yes, looks perfect. Thank you very much, Dr. Pizzetti.
Okay, so this is a really important subject. We could spend like maybe 2 days talking about medication reuse headache, but I know we have a short time, so I will try to be objective and clear, and to use some practical tips that I can give you. But first, we need some introduction. So medication reuse headache, which I will refer as MOH, only happens in patients with a pre-existing headache disorder, which is usually a primary headache. Analgesic overuse can be caused by other painful conditions, such as low back pain, neck pain, and arthritis. And the diagnosis of MOH implies that the overuse medication is the cause of the frequent headache. The most commonly used drugs are triptans, simple analgesics, and combination analgesics, as well as opioids. And depending on which country you live at, you'll also find some patients that use a lot of barbiturates and ergotamine. But most of these patients with MOH, they take more than one drug class. And since MOH is in principle preventable, we need to talk about it. Like many cases are iatrogenic, especially those that the overuse medication requires medical prescription to be bought. And I'm sure it is exacerbated by poor medical advice. So talking about epidemiology, we know up to 2% of adults have MOH, and the most part of its population is female, and that makes a lot of sense since the most common headaches have a female prevalence. It tends to develop years after the onset of the underlying headache disorder, and it accompanies the prevalence rates of migraine and tension type headache. And that also makes sense because these are the most common two headaches that are the underlying problem. And so prevalence will increase with age until middle age. And though MOH is not as prevalent as migraine or TTH, it is the most prevalent chronic headache type. 70% of patients with chronic migraine have MOH, and migraine is the underlying headache disorder in 80% of patients with MOH. And it is among the costliest headache disorders, and 92% of its cost is attributed to presenteeism and absenteeism. We are not sure if the risk factors are directly or indirectly associated with MOH, but we know there are a lot of patients with psychiatric comorbidities, especially depression and anxiety. And these both are also independent risk factors for chronification and for MOH, and they're also predictors of worse prognosis. And among the genetic risk factors, we see mostly ones involved with serotonergic and dopaminergic transmission, as well as ACE polymorphisms. And you will find that many of the probable risk factors are shared with other chronic headache conditions. Its pathophysiology seems to be headache specific, as patients with episodic headaches may develop MOH if they use analgesics for other painful condition, but the other painful condition does not get worse. And it is hypothesized that MOH influences neuropathways of the underlying headache disorder. And this is why it looks like the headache is getting worse along the years, but it looks like the same headache that is progressive among a long time. And we have evidence of functional and structural changes in neuroimaging studies. And curiously, some of the state of these alterations normalize after MOH is resolved. And it is better studied in association with migraine. So can you see the whole picture here? Or is the bar on the top of it? I'll try to change.
Sorry, no, I mean, we can see.
Okay. So I will try to summarize the pathophysiology into figures because it's long and I don't want to be writing the slides for you. So what you have here is that C and A dental fibers become prominence-receptive, and they transmit peripheral input from painful headache and neck structures to higher dorsal cervical roots and the trigeminal ganglia, leading to sensitization of second-order neurons in the trigeminal nucleus caudalis. I'm sorry, can you see the arrow? I hope you can. And this, in association with noradrenergic and serotonergic inputs from the dorsal nucleus and the locus coeruleus, will be transmitted to third-order neurons in the thalamus and in the somatosensory cortex for sensory integration and central sensitization. And we will also have dopaminergic input from the VTA, which is the ventral tegmental area, which is here, to the basal ganglia, and it will be involved in maintaining the habit to overuse medication. And we all know that the amygdala is involved in dependency behavior, and the periaqueductal gray and the rostroventral medulla will show decreased inhibition and increased facilitation of pain transmission. And here, what you have from the peripheral sides is that the use of triptans and opioids will sensitize the trigeminal ganglion neurons, and it will result in the increased expression of CGRP and neuronal nitric acid synthase. Here you will have neuroendocrine mechanisms as well as prolactin. They will increase the secretion, that will contribute to pain sensitization. Here, number 3, we have increased transmission from the trigeminal ganglion neurons will promote sensitization of secondary neurons in the trigeminal nucleus caudalis. And this will involve long-term potentiation and NMDA receptor. And here on number 4, we will find that medication overuse will promote adaptations in the descending pain modulatory pathways that involve serotonergic and noradrenergic signaling in favoring pain facilitation and diminishing pain inhibition. And we cannot address MOH without noticing that these patients, they have a behavior phenotype. And so the most frequent comorbidities of MOH are anxiety and depression. They also commonly show dependence type behavior, and it's very common that they show ritualized drug intake and psychological drug attachment. And that happens because they are afraid of missing out important life events. And they also have worse response to acute medication, which leads them into taking even more medication. And it is not uncommon, actually, it is very common that these patients, they have aggravation of pain when they try to pause or to terminate the use of the acute medication. And when we talk about MOH, we have to address cephalogiophobia and avoidance behavior. So what are the things? Cephalogiophobia is the fear of getting a headache or of worsening of the pain while it still is mild. It could be a form of anxiety disorder. It is linked to the progression of episodic to chronic migraine and to medication overuse headache, and it decreases the threshold for consuming analgesics. And what is avoidance behavior? Avoidance behavior is a conduct that the patient acts in order to avoid a potential trigger for a headache attack. And when you put it in these words like avoiding bright lights, loud noises, or certain foods, it doesn't seem to be so hard. But when you translate this in real life, you have a patient that no longer engages in conversations with their parents because they have a little bit of hearing impairment and they have to speak a little louder. They don't do outdoor activities when the sun is bright, and they cannot go to places with live music with their friends. So they will skip social and professional events. And this is a very cruel disease because the patient is already deprived of so many things, of the joy, at least, when they're in pain, but they also have a lot of complications on painless days. And it will also lead them to refrain from physical activity, which is something that helps us along the way in the treatment. And it is very common for them, again, to show pain catastrophizing. And I think we all see this very commonly in the office. They have anticipatory anxiety and they have obsessional drug-taking behavior. And even though they are aware that they're taking medications too often, like what other choice do they have if they don't have good medical advice available, right? And it is very common for them to use overuse other types of medication like eye drops, decongestants, laxatives, and sedatives. I think that what we see mostly in Brazil, it's zolpidem and clonazepam, which curiously are medications that don't even help with the pain, they just make you sleep. And they also use a lot of muscle relaxants, which are inefficient drugs, and this most of the headaches, so it makes no sense. This is all due to poor medical advice. And since most of our population here is women, we cannot avoid talking about gender-specific factors, right? So we know that menstruation is a trigger for about 80% of women, and this is due to rapid falls in estrogen levels that decrease serotonergic tone. And we also know that perimenstrual migraine attacks are more severe and more refractory, so they lead patients into taking more acute medication. Another difficult phase in a woman's life is the perimenopausal phase, because again, migraine tends to get worse, again, because of the oscillated levels of estrogen. And we have evidence that estrogen modulates vulnerability to cortical spreading depression in female mice. And we hypothesize that this can happen as well with human women. And so what is the clinical presentation of MOH? So what you find is a patient with gradually worsening of headache despite the frequent use of painkillers. They always come saying that medication that previously worked no longer help, and they have to take more and more medication, and everything trying to relieve the headache only seems to make it worse, but still they feel that they need to take something. And the phenotype of the pain will be determined by the pre-existing headache and the type of medication that is being overused. And you can find that sometimes the characteristics change over time as MOH develops. And this might make it difficult to give the diagnosis of the underlying headache disorder in the first encounter. So don't worry if you cannot do it in the first time. And what we see is that frequent users of triptans will develop daily migraine-like pain in the morning that disappears after triptan use and comes back again maybe in a couple of hours or in the following day. And this is easily confounded with red flags that are pain that wakens the patient up from their sleep and pain that is worse when you wake up in the morning. And we see that patients who mix medication classes report more frequent drug use and fewer crystal clear days than those who just use triptans. And this is a personal tip that was told too late in life, that when you have a patient with frequent headache, you don't ask them how often do they have headache, but instead you should ask them how often they have crystal clear days, because patients tend to underestimate the days where they don't have severe pain. So we're reaching diagnosis. So what you have is a patient with a previous headache condition, and they had an episodic pattern that evolves over time. Usually takes some years to get to MOH, and medication use is taken into account, even when it is used for other painful conditions. And it might not be easy to determine the taper relationship. So what came first, the frequent pain or the overuse of medication, especially because these patients have an average of 20 years of headache and 6 years of medication overuse. So they might not remember, so you have to treat it anyway. And as other headache conditions, you should search for red flags to assess the need for complementary exams. And the diary here will be indispensable both for diagnosis, but also for monitoring outcomes. And it's very good for the patient to see how often do they have headache and how often they're taking medication, and then to see how it improves afterwards. And here it is, the diagnostic criteria. So you will have headache occurring on 15 or more days per month in a patient with a pre-existing headache disorder, which is in regular overuse for over 3 months of one or more drugs that can be taken for acute treatment of headache, and it should not better be accounted by any other headache condition. And before we reach treatment, we need to talk about prevention, because MOH, at least most cases of MOH only happen because healthcare providers and patients are not aware about it. And it might seem contradictory to many people, and doctors in this case as well, that taking painkillers for headache will only induce its worsening. You know, like everybody has heard of some colleague advising a patient that they should take the medication when there's a trigger, sometimes when they don't even have pain yet. And a fun fact is that now the FDA requires companies to add facts about MOH on the labels of over-the-counter drugs that are sold to treat headaches. And now we reach management, and something you cannot forget is that this whole treatment revolves around the patient. We cannot do this by ourselves. So the most important step is to prepare the patient. You need to be patient and available. You need to spend time explaining to the patient their importance in this treatment strategy. They need to understand their role in this. You need to explain the reasons for withdrawal. And these patients already feel so much blame because they miss everything, like they miss encounters, they miss their social life, and they're already so stigmatized by their families and colleagues. Many people just think they're just not trying hard enough, you know? So please do it, use it gentle language with no guilt. You should give them detailed information about the nature of MOH, and you need to directly ask the patient if they think they can stop overusing medication, because if they cannot, they just will never show up again. Like you were a doctor they just met, you cannot just tell the patient that the only thing that seems to help them needs to be stopped. It just sounds like torture. So you need to tell them how it works. And in the first encounter, you should also teach them how to make a headache calendar. And as it will happen for other headache types, the choice of the prophylactic drug will be based on the pain phenotype and the patient's characteristics. We have clinical evidence that the majority of patients with this disorder will improve after the discontinuation of the acute medication. And you can propose both early discontinuation with or without preventive medication, or or early preventive medication with stepwise drug discontinuation. About 70% of patients will revert to the episodic form, and this should be taught to patients because they need to have real expectations. You're not promising them they will be cured of headache, but once you put this in the appropriate words, it will be enough to convince them that just their life is going to improve. And in simple cases where patients only overuse triptans or simple analgesics and didn't have major psychiatric issues, you can just try advice alone. Sometimes it's enough. So the overuse medication should be discontinued or their frequency of use limited to up to 2 days a week. It is proven that complete discontinuation is more effective than restricted use, that discontinuation was superior to no treatment, and that discontinuation plus preventive treatment was superior to discontinuation alone and to preventive treatment without discontinuation. So you need to inform the patient about potential withdrawal symptoms, and the most common are headaches, of course, hypotension, tachycardia, restlessness, anxiety, and sleep disturbances. It tends to be shorter to patients that only overuse triptans, and many patients will experience initial worsening of the headache, so be prepared. I advise that you should do this while you're available. So maybe if you're just getting on vacation the next week, you can propose to the patient to do it when you come back, so you are there for them. You need to be available, but mostly you will get better in maybe 2 or 3 weeks. And since you cannot take a step further in this treatment without passing through withdrawal, and this is really energy consuming for the patient, you should consider giving them a sick leave, because this is really important. When you have available, you should offer nursing and psychological support. And we all know that opioids and barbiturates should be tapered down. You cannot take it all at once, and probably as inpatient care, just to be more careful. And as an exception, in difficult cases, you can change the acute medication that is being overused for something from a different class, but of course we limit the use. And once MOH is resolved, you can even bring back the drug that was being overused, but with limited use. And there's no strong evidence for this, but the drugs we use to go around withdrawal symptoms are usually the same we do for status migrainosus. And also about the withdrawal phase, when you have patients with serious psychiatric issues, when they overuse medication from different classes and who have previously failed to attempt to withdraw, you should consider inpatient care. And this is more of a personal tip. I think it works a lot. I really like to use occipital nerve blocks as a bridging for prophylaxis, as it is really safe. It is available everywhere once you know how to do it, and it has a fast onset of response. The prophylactic treatment, if you do it, of course, it will help reducing the pain intensity, the frequency, and the intake of the acute medication. I'm sorry. And again, there's not strong evidence. It's only weak and moderate evidence. And you can see most of these drugs are used for migraine, but you can use topiramate, Botox, all the CGRP monoclonal antibodies, and the JPENs. And since we use JPENs both for acute and prophylactic treatment, in theory, they don't cause MOH. So it might be a good choice if you have them available. And of course, if you feel it's appropriate, you can also use beta blockers, flunarizine, or amitriptyline. And I know it takes a lot of time, but it is really important that you talk about everything with the patient. And you should also address subjects like pain coping methods. This is really important. It's very nice to work along a psychologist to help with this. You should ask them about their anxiety and depression symptoms, and also suicidal ideation, always in chronic pain conditions. You should encourage for lifestyle changes. And there is, again, big evidence for this, but it is always good to have a card up your sleeve in these cases. You should advise for behavioral interventions, acupuncture, and neuromodulations in cases of MOH associated with migraine. And what is the prognosis of these patients? So up to 41% will relapse, and most of them in the first year. But relapsing rates tend to be lower in patients who keep in touch. So offer close follow-up, ideally every 3 or 6 months. And success in the first year will be associated with a good long-term prognosis. And you should keep a close eye to patients that have risk factors for relapse. And the most important ones are opioid overuse, greater number of previous preventive treatments, longer duration of MOH, patients who have the association of migraine and tension type headache, when the patient is admitted to the hospital after discharge, and when they have important behavioral symptoms. And I think, I'm sorry if I went really fast, but I will leave you to this last slide, which is a resume of everything I talked about. And I hope I could give you some personal tips and practical tips for your daily practice. That's all. Thank you very much.
Thank you, Dr. Pizzetti. A wonderful presentation. I have a few questions for you, and I will start with medication overuse headache. Is it possible to have medication overuse but not be contributing to chronification of migraine, like a patient who's taking more than 15 days, but that is not the cause of the chronification of their headache? Is that possible?
It is not impossible, and sometimes it's not even clear when you try to take the history, but even still, like, since 70% of patients will improve, and many of them, like, if they feel they can just stop or use the medication, you will see that many of them will improve, like, at least a little bit. But if they don't, it is also a poor prognosis factor.
And how often do you see medication overuse headache in your practice as a neurologist?
I'm a little bit biased, but I think that 80% of my patients have MOH, which we just talked about this in our class today. Here in Denmark, they no longer see as much because they educated population, so they're aware of it, and it doesn't have the same rates. But in Brazil, we see a lot, especially because not everybody has accessibility to neurologists, and even among neurologists, many people don't know and don't teach about MOH to their patients.
Okay, so the next question I have is, sorry, can you see me?
Uh-huh.
So the next question I have is around what medications are most implicated in medication overuse headache?
So usually simple analgesics, combination analgesics, triptans, and in some countries like the US, opioids.
And the headache calendar is a very important tool for managing migraine. I know in our region, in the Middle East, and in a lot of patients do not come to practice with a headache calendar. How common is a headache calendar in Brazil?
Oh, it's hard. Mostly they still like the paper calendar, which I find not really convenient, but it works. Like once you really get to talk to the patient and educate them about this, they get involved in the treatment, and it will work out better. Like, it might even be, I never heard anything like this, but it might even be a sign of good prognosis that they're involved and they're just filling in the information from the calendar.
And how do you encourage your patients to start a headache calendar? If they have medication overuse headache, do you first treat and ask them to have the calendar, or do you first start the calendar and then treat?
Usually I do both. Like, we all know in real life, sometimes you don't have the time you need. Sometimes you have like 15 or 20 minutes. But I try to give them like a brief. And if I feel like I didn't give them enough information, I ask them to come early. Like, don't wait like a couple of months or 3 months like we usually do. I ask them to come like maybe in 2 weeks or in the end of the month, just to recheck again. And it is very, very useful to have somebody helping you, like a nurse, you know, and a psychologist to give you just like the support for the behavioral issues. But the key of it, like, there's no way you can do this without spending time talking to the patient. That's the main thing.
And do you see more women than men with medication overuse headache?
Yes. Almost 100% of patients with MOH will come from migraine and tension type headache, and this is mostly women. So yeah, I think it's usually, well, like women in their 40s most of the time, and because afterwards, especially after menopause, the migraine tends to relieve a little bit, so it gets better.
And I have a question from one of our guests, and it's outside of medication overuse headache, and it is around what percentage, it's outside, but I think it's very interesting that we have you online to answer this question for our guest. And the guest is asking what percentage of inheriting migraine where the father has, the question comes from someone who's asking, my daughter has been complaining of continuous headaches, and I don't want to believe that she has migraine. How would you answer this parent?
You don't want to believe? I know. The first thing one of the most important things, like, is to accept. And we talked about this before in other cases. Like, the first thing is they're always looking for something else, you know. They usually, patients they have been to all doctors. They have been to the ophthalmologist, the ear, throat, nose doctor. They go to the gastrologist because they think it's something they ate. It's something that happened with theirs. Like, there's always a trigger, but in fact, like, I think once you talk to them and you help them accept the condition, it is the first step. Like, you cannot go take the next step if they don't know what they have and if they don't accept it. It is, but it's very hard to have, not as much as migraine. Sometimes it's a relief to have a diagnosis for the patient so they can understand what's going on. But if MOH, there's so much stigmatizing about it, and it's hard to convince the patient they have to take it out. But the first step is to convince. But it might take you some visits with the same patient to convince them.
So I don't know if we answer this, but I know that if one parent has migraine, the odds of your child having, or the child having migraine is 50%. If
42.
Both parents, it becomes 75%. So I myself, as a practitioner, would say, do not be afraid. Diagnosis is always the first step towards a solution. And again, as a parent, I would say children are more resilient than we are. If the child knows early on, they will make the lifestyle changes easier for them to make these changes. If you explain to them the condition, it's a neurological condition, but it's manageable. And we're very lucky. We have a lot of options now that we didn't have before. We know more about children and migraine. So don't be scared. Don't be worried. Don't be in denial. Actually embrace it. Acceptance is great for people living with migraine. And parents, I know as parents, we want to protect our children, but we also need to help them live a healthy life with a good quality of life. So that's my answer also to the patient. The next question I have from one of our patients is, why does Rimegepant not cause medication overuse headache? Do we know the answer to that?
I'm not sure I would know the answer for that, but it works as it is what we see. We don't have much time of using these drugs, but they're also used for prophylaxis. And we see that there's, as time goes by, they have less frequent migraine and less frequent use of acute medication. So that's why it works. But I cannot tell you like the specific cause. It's just like what has been observed.
Yes, and I agree. I'm not sure if there's an explanation yet. So long it has been observational from clinical trials and from actual real world experience, we don't see it. I don't see it with my patients, actually. Now, the next question I have from one of our listeners or our audience today: how can we convince patients to stop taking medication, especially when they are suffering? is the question, I think, is is placebo useful, or how do you help them?
I don't know. It doesn't seem too fair for me to give them placebo because you just have another problem and they will have something in their head. But there might not be a solution that could work for everybody. But again, like spend time talking to the patient, do it using gentle language, give them the reasons of why it works, give them evidence, and they will believe you. And sometimes if you cannot stop it, you have the option of just trying to decrease the amount of use, which is limited to 2 days a week. And then you can try to give them some help, like you can use a short term of, again, there's no strong evidence for this, but you can use a short term of corticosteroids and maybe give them a nerve block and something that can prove them that they can handle it. Because you don't have, like, once the pain is diminished and they understand what they need to do in this treatment, they're probably going to engage. But of course, there are always those patients that they say, I cannot stop overusing, I need to take something every day. But the diary will help in this way, because you will show here you have like severe pain every day and you're taking 4 pills a day of some painkiller drug. Do you think this is really helping? This is not helping you. And they also have a lot of side effects from taking so much medication. They usually have gastric complaints and dizziness, or they feel sleepy, or they just spending so much money in these triptans and all these other drugs. You know, you need to convince them, but the only way to do it is being polite and giving them evidence.
I will possibly ask you to comment from your own experience. From my experience, when I speak to my patients and I explain to them what is happening, I use language that is close to them. So when we talk about medication overuse headache, it doesn't at all register with my patients. It doesn't mean anything to them. And overuse, as you said, might imply blame, that you are overusing the medication. While when I explain to them that your body now is used to this medication, so every time you stop, you have a headache, and that's why you're taking more. And I give them the example of coffee and say, look, when you drink coffee every day, if one day you don't drink coffee, you will have a headache. So this is exactly the same. And I would like us to first start and reduce the effect that taking too much medication has on your migraine. And then we're going to start and adding, it's not like you cannot take any of these medications forever. It's only that there's a detoxification. You try to find the language that is closer to what the patient understands and that is closer to them. I don't know if you do the same, Dr. Pizzatti, in your practice.
Yeah, and sometimes, sorry.
I'm sorry, but I find very little resistance as well. It's not like they say, I do have patients who say, I cannot take the pain, you have to give me something. But very surprisingly to me, as a person who doesn't live with migraine or medication overuse headache, a lot of them go like, well, I'm gonna do it. I'm gonna work with you to make it happen. I find less resistance than I expected. I don't know what you think and what you experience.
And maybe you shouldn't use some words like, at least in my language, in Portuguese, I don't use dependency. I don't use the word. I try to use like more like rebound, to rebound effect of the medication. And sometimes they even say like, I believe you and I trust you, but it's just that I cannot do this by myself. Like, I don't have confidence in myself. I know I cannot stop it. And then that's why you should be available. You can say like, I can give you the day off if you feel like it's a really bad day, or that you're not going to make it, or that you just need to rest. And maybe if you need a nerve block or something, you can come in and I will surely will attend you sometime in the same day, you know? So that's the key, like, be available. I know it is hard these days to be available, but that's one of the answers. Like, if you show you're available, they will trust you better.
And the next question is, do you find it works better to continue? I know you talked about this cold turkey, stopping the triptan cold turkey, or have them reduce slowly. I know that you had it in your slides, but just for this person who possibly joined a little bit later, what
Cold
works?
turkey is abruptly, right?
Yes, yes, I'm sorry.
It is.
Very, very American.
It is what works better here. Actually, here in Copenhagen, they had this trial. It was very good trial because everybody had doubts about it. That they tried all these options, like the cold turkey, just stopping acute medication, or just starting preventive medication, or giving a limit and starting preventive medication. And the thing that worked better, they hypothesized that just stopping abruptly will be the best choice, but actually it was stopping abruptly and associating prophylaxis was both things. This had the best results, both for improvement and for less relapse.
Okay, then I have the next question that is, do you give a medication holiday for medication overuse headache so you can start again with monotherapy? So again, I think it's the same. You don't stop and do nothing and then start. I know that the best evidence today and the most humane to manage medication overuse headache is to try a preventive, to start a preventive as soon as you can. And that will give them some effect while they are also reducing. And that is the most effective. Has this changed with the introduction of CGRP antibodies and GPAN?
I find it's easier. There's some patients that say they could, that's the key, you should ask the patient, is this a conversation? You're not just saying you should do this, and that. You can ask them, do you think you can do this? Because like, I can help you with this. Do you think we should try this other thing? Like, you can give them options and they can choose. And that's the fairest way, I think. But CGRP has shows improvement, as we've seen in papers, that even with very severe patients that had they were resistant to 2 or 4 prophylactic drugs before, and they have a faster onset of response, like 2 weeks. You can set apart 2 weeks of comparing with placebo. They're better, they're significantly better in 2 weeks, which differs from most of medications option from the other options we have. And we can see that many, depends on where you live, you also like try to add more drugs, or you just change one from another, so you're not increasing the prescription. And the CGRP antibodies are really good, and we see a lot of patients that once we started, we even start taking out the other preventives, because sometimes it has such a good result. Of course, it's not magic, it's a medication, it's science, but I think it was a breath of fresh air when something new came in that gave us more option and hope.
So I have, there's a lot of questions still, but I just wanted to ask you one last one. We know that it's pretty late, and we took a lot of your time, and we're really, really grateful for you being with us tonight. The role of vitamin B2 and magnesium, is it something that has any impact on medication overuse headache management at all?
There's more evidence for this for migraine, but anyway, it is not first or second line treatment. If you feel like some patients, they have this obsessive thing with medication and they feel like they need to be in controlling the pain, and it has to do with MOH. Many patients have this kind of personal behavior profile, but like maybe to make them more feel more empowered, you can give them something so they just know they're not like rather taking something for the pain. But I do not believe this will lead into a higher success rate, because the answer here really is to diminish the use of acute medication. Like, of course you can take it, but it's not going to be what's going to solve your problems, probably.
I know I said it's the last question, but the questions are still coming in. So it's a very interesting subject, and we have a lot of questions from our viewers tonight. One question that I really like is, what is the impact that having too many medications that are abortives, like and medication overuse headache, that cause medication overuse headache, and memory impairment, and
I wouldn't know to tell you about this, but it is usual that patients with chronic pain conditions have great complaints about memory, and also because they have sleep disturbances as well. It's very common for them to have poor sleep quality. And some of these medications, especially topiramate, of course, it also decreases your memory. So you should, I don't think it should be a major concern unless it's a adverse effect from a medication. It is a problem. It will probably get better as sleeps get better and their behavior gets, like anxiety gets better and depression gets better and the pain goes away. It won't be as much as a complaint.
Thank you very much, Dr. Pizzetti. This has been, and as I said, the questions are still coming. I know we have to let you go, but we thank you very much for joining us tonight and for this very informative session. If you haven't joined us from the beginning, I saw some questions that Dr. Pizzetti has already answered in her presentation. So if you haven't joined us from the beginning and you still would like to hear the answer to your question, a lot of this was covered by Dr. Pizzetti in the beginning of the presentation. You can go back to the recordings. The recordings will be on the IVPN website very soon. So keep an eye on that until it goes live on our website. Again, thank you very much. We really appreciate you taking the time and all the work that you have done to ensure that you covered this subject beautifully. Thank you very much. And we wish you a great day today or a good night. Thank you very much. So again, if you have just joined us, I would like to remind you that the question and answer for the next session is going to be in the question and answer panel right at the bottom of your Zoom. I would like to also, I can see we have a lot of viewers online. I would like to tell you that something that is very dear to my heart myself, the Master of Headache Disorders is a program that is offered by the University of Copenhagen. Every 2 years, they accept 22 candidates from around the world. They do accept neurologists, they do accept nurses, they do accept GPs with special interest in headache, and the registration has, or the application has just started this week, and it will be open until the 1st of May. I encourage you, if you want to learn more, to go to the website of the University of Copenhagen. I have just put a link in our webinar chat. It's a beautiful program. Again, I'm saying this out of experience, as I have experienced this beautiful program, one of the best in the world, where you get to meet the best researchers and professionals in the headache world. At this beautiful location in Copenhagen in Denmark, and you get to do your clinical at the Danish Headache Center, the best headache center in the world. Again, if you've just joined us, if you want more information, I've just put the link, and it's the applications have been open. 22 every 2 years are accepted into this program, an international program that is very, very interesting, and that it really helps you take care of your patients at the highest standards possible. So I will go to the next part of our presentation tonight, and it gives me great pleasure to introduce Dr. Manal Faham. Dr. Manal, I'm not sure if you can switch on your camera so that our members and our viewers can see you. And
Can you see me? I switch on already.
Yes.
Can you see me?
Now we can see you. So I'm just going to go ahead and present Dr. Faham. Dr. Manal Faham is also a specialist neurologist from the United Arab Emirates. Dr. Faham has years and years of experience in the region and advanced certification in neurological disorders, and is an expert on headaches and migraine. It gives me great pleasure to welcome you tonight. I know that you're going to talk to us about rimegepant and one solution for acute and preventive treatment, and what is the evidence for rimegepant. And hopefully we will also hear your own experience with rimegepant in your practice, and again, in continuation of medication overuse headache, your experience on the subject. Welcome, Dr. Manal Faham, and it gives me great pleasure to welcome you tonight.
Yeah, it's pleasure for me also to participate in education. I like really to work in general education for all physicians and in public as well. It's part of my interest actually. Shall I share the screen already now?
Yes, doctor, please share your screen and you can start your presentation.
Yeah.
So we can see your slide perfectly. You can go ahead.
Okay. I want to start in the beginning to just talk about the past days. I have been working as neurologist since 1995, and I still remember, and we are still also now seeing that we are treating migraine with multiple type of medication, which is not really specific. And if we talk why people are, they don't know that there is treatment of migraine, why 2/3 of patients, they don't really come to take preventive medication of migraine, because they still think that there is no specific management for migraine. We are treating migraine with anti-epileptic medication, we are treating with cardiac medication, sometimes with antidepressant, even the patient is not depressed. SSRI is part of treatment with a lot of pain medication. So we were following closely since 1980, as you see, that they discovered a new mechanism that's really specified for migraine. And we were following all the studies evolving until the first medication that is launched under the mechanism of CGRP, serotonin gene reaction protein receptor. And this was really fascinating. And I really remember in 2018, when the first medication that is specific for migraine is launched and approved by FDA, then by European. And it was really fascinating for us and strange. And then I feel now proud that I am alive in the time that the most common illness in neurology, we have a specific treatment for that. It is part of the history, I think. And when the rimegeptan also was launched, it was just recent, 2020, for the acute management of migraine. Then it was approved in the 27th of May 2021, after the COVID area, for the preventive management of migraine. So we have all the shadow that we need currently for all the type of the patient. So first clinical trial of Nurtec, it was 2012, and see how long it take from 2012 until 2021 until it is launched. So it was a very long study for the safety, for the efficacy, for all the side effects. So that's why this medication are really effective and safe. What I want to say that, as I said, for acute management is approved in February 2020. Then for the preventive, it was approved for the preventive management. Again, we are back to the old, the previous, I mean, the basic management of migraine. We are still using. We didn't move immediately fully to the new medication. I think that in the coming years, we are going to shift directly to the excellent medication that are safe and effective, and depending on anti-CGRP mechanism. Currently, we are still using triptans, we are still using all the type of pain medication. So we are going to talk about the triptans because it's one of the medication that are overused for migraine, and it has a lot of side effect. And I have many ladies who got cerebrovascular accident from overuse of triptan, and they couldn't stop it because of side effect of the severity of the migraine. So triptan is really effective and has fast onset of action for migraine attack. And however, it has a lot of contraindication. It has, because it's depending only on the vasoconstriction mechanism. It's anti-pain medication. It doesn't prevent all the shadow of the multiplicity of the symptom that is associated with the wave of migraine attack, starting from the aura, going to the prodrome, to the maximum headache, where there is dizziness, there is fogginess, there is impulsivity, there is polyuria, nausea. There are many symptoms that come one after the other due to the spread of the wave of the irritation through the deep nucleus of the brain to the cortex. So triptan is not treating all that. Triptan is treating only the vasodilatation mechanism that can cause the severity, the pulsing effect of the migraine, and the feeling unease and puffiness in the head and eye in the face. So that's why it has fast onset of action, but it treats only the pain. So, and it can cause a lot of side effects related to the vasoconstriction mechanism. Especially for the patient who has cerebrovascular disease or hypertension. So it is generally effective, and it is efficacious even in more than 40% because it has short lifespan, so it can be repeated. Switching to a different triptan is also, I don't advise. I didn't see any patient that responded to the third type of triptan. Usually first and second type, they usually fail all the triptans. However, people are really trying multiple brands, as you know, because it is becoming over the counter in many countries. 42% of the 183 patients that are surveyed on usual care were dissatisfied with the need for the rescue medication. Actually, 43 of the patients on triptan experienced treatment emergent adverse event or side effect within 24 hours. They have chest pain, chest discomfort, they feel really dizzy, but as we know that there was no many other options, so people tolerate the side effect reaching to hazardous on the life, as I said, because I really have patients who got cerebrovascular disease and coronary artery disease as well. It was exacerbated by the use of triptan. In the survey of 5,590 patients with episodic migraine in the US in 2009, there was like 10% of the patients reported a history of cardiovascular event, as I said. In my experience, the number is more than that. Many patients, they don't remember to tell their doctor when they go to emergency room that they are taking triptan. They don't really tell. If they go with chest pain, they don't remember to tell us that we have headache, we have migraine, and we are using other medication. If we don't ask them, in my experience, more than 10%. I think it can reach 15% easily, actually. Recently launched preventive monoclonal antibody. We are talking about the anti-CGRP, the new mechanism, as I said, and it gives us an excellent option for specified management of migraine headache. And as I want to say in that regard, that migraine, we want to remember when we are educating others that migraine is a vascular headache. It starts with a trigger at most of the time, sensory trigger, like from the vision, from the nose. Then there is some irritation going inside, making increase in the CGRP level. But the end result is a circulation. There is vasodilatation and vasoconstriction. So it is related to the circulation. That's why we need to know that all the shadow of symptoms are most usually there is hotness feeling, there is pulsing feeling. We need to when we are teaching the people when to take their medication, they can really feel the onset of the attack and the wavy pattern, how much it is repeatedly happening. So that's why I am saying that, because when when the patient take the medication delayed, they have more side effect with the triptan. While this does not happen with the new mechanism of the anti-CGRP, because it is not specified to the vasoconstriction effect. A long half-life does not allow the immediate cessation of treatment. Here they are saying that the triptan is not allowed with pregnancy, with hypersensitivity reaction. Of course, we have a lot of contraindication. Migraine attack often affect women. Of course, in that childbearing age, it is not really good for that. 34.7% of the patients receiving 6 months of, now we are talking about the first and second medication that were really effective and safe for the management of migraine, which is Irunomab, the two injectable form, Emgality and Aimovig. They were very good, but the long half-life, we give injection for the whole month, then we cannot stop the medicine if the patient got pregnant. This is so much limiting our use. And also, if the patient is planning to get pregnant, we need to stop the medication. I advise like 2 months ahead, because we don't have safety profile for pregnancy. That's why here the need of having tablet that can be stopped immediately. And if the patient discovered that she is pregnant is a mandate, and it was a necessity. That's why the launch of this Rimegeptan, it was really important for the ladies who are, most of the patients are ladies, actually. 2/3 of the patients of migraine are ladies, and most of them in the child bearing age. There was a questionnaire about 500 migraine patients, revealed that actually this one is coming in the middle of my, yeah, let me take it like that. Yeah. More than 60%, they prefer to take oral medication because they can stop it. They can, some patients, I noticed that they like to take it only per need, and they found effectiveness. We are going to talk about that. So they tell us, yeah, I prefer tablet. Maybe I take it every other day as a preventive, or I take it every third day, or only per need. Maybe I would improve. And nowadays we are combining both the oral form, Rimegeptan, with the injectable form, because it can be combined for PRN use only. So people, they like to have tablet. They prefer, many of them, they prefer tablet. Many of them, they have fear of injectable form, especially of the local side effect, hypersensitivity. And as I said, that we cannot stop it once we give the injection. Polypharmacy is common among migraine patients, as we see in my colleague, she was talking about over-the-counter multiple pain medication. Of course, they are coming with multiple psychotropics as well, multiple SSRI and many other anti-anxiolytic medication. So the patient in that case, they like, yeah, when they have a need for preventive medication, and there is need for more safe medication. That's why the polypharmacy overuse medication. I think I don't like to repeat what she said. There are many types of medication. She talked about it in a very, very good presentation. Triptan, non-steroidal anti-inflammatory, and the opioid, which is addictive. Barbiturate, also addictive medication. And ergot medication is still somebody is using, but it has extreme side effect on the circulation. I want to say that I have many patients also overusing non-steroidal anti-inflammatory. We found that they have mild renal impairment. Today, I got one patient who is only 35 years old, and he came to me with elevated creatinine. And I found that he is taking almost over the last 5 months every day non-steroidal anti-inflammatory with a paracetamol. So we find a lot of side effects of those polypharmacy. Medication overuse is increased. Again, I don't want to repeat, but they are talking about the cost, which is an important also index that we see why we have to move to specified medication for migraine. This is very nice. I like to explain it a little bit. The cost for patient, the direct cost of the medication, it takes 22% of their income. And the indirect cost, it takes 77.3% of their income. The indirect cost, like visiting other subspecialties, going to psychiatry, to gastroenterology, endocrinology, even many psychology also, they visit many patients. Then the indirect cost is the loss of job effectiveness, the multiple being absent from work, So there is a severe cost, a very high cost that can be reduced by proper management and reduction of the pain and disability that is related to migraine. So they say that about a very high percentage of the income is only oriented toward managing migraine, and managing migraine effectively, even with more expensive medication, is cost effective at the end. Again, we are talking about medication overuse headache because in the chronic migraine, we found that overuse medication is causing the transformation from episodic migraine, infrequent attack, to more frequent attack, which we see in our life, depending only on pain medication. It increases the frequency of attack and the severity and the duration until it become attack or become like congruent altogether, and it turn to chronic migraine. And we find that every year 3% of the patients are turning from episodic migraine to chronic migraine, which is a severely disabling disease. And migraine, as you know, is the second disabling neurological disease after stroke. It is more disabling than multiple sclerosis. And we are seeing that because it is affecting our daily life. It's not an attack that comes every 6 months, every year, 2 years, like that. It's really more disabling than multiple sclerosis. Medication overuse can increase the risk of progression by nearly 20 times. As I said, from episodic migraine to chronic migraine. There was a study that is conducted to see how much the percentage. In a study of 500 patients with episodic migraine, the odd ratio to go to chronic migraine was 19.4%. In this sample of 532 patients, comparing with and without medication overuse. One study revealed that 180 patients with chronic migraine and 127 patients, like 69%, were overusing acute care medication. Yeah, we asked, the doctor said about 80% of the patients are overusing, of course, because they have still severe pain. Sometimes we cannot define exactly the borders between medication overuse and having pain, really, and not finding the right medication to reduce their pain. Chronic migraine is really 3.6-fold more costly than episodic migraine, which is well understood because it affects the lifestyle. And here they are making nice comparison to show between countries how much the cost of chronic migraine to episodic migraine, estimated cost in Britain, in France, in Germany, in Spain, and as you see, I don't know why in Britain is ranking the first per population. It's really a big amount of money. Now let's talk about the mechanism of action. I like to show you the next slide. I will just read a few lines here to show you the mechanism in simple photo. This rimegeptan Nurtec is the only oral anti-CGRP for acute and preventive medication, as you know. That's now I can explain the question that passed before, why it doesn't turn to be one of the medication that is overused, because it can cover both acute and preventive, because it has a long life, and because it is not working on the pain only, it is working in the main mechanism of triggering the migraine attack. So it can reduce all the shadow of all the symptoms, starting from the prodrome to the aura to the postdrome. All it will be reduced altogether, and it has a long life of action. So there is no need to take another medication. That's why there is no overuse of the medication. But Also, I think that there is no overuse. Another factor, because it's still a little bit expensive. So people are counting the tablets and they are counting the effectiveness of the tablet, to be frank with you. Nurtec has already received regulatory approval from FDA, as we said, in the acute management and in the preventive in the 2020-2021. Acute treatment of migraine with or without aura in adult, the dose is 75 milligram, one tablet to be taken as PRN. When we take this medication per need, we can take it daily for 1, 2, 3, 4 days. Actually, I noticed from my experience, they never need it, really. It is very good and effective drug. I tell the patient, you can take it 3 consecutive days, but not the whole week. But they really don't need it. Preventive treatment of episodic migraine is every other day, one tablet every other day. And we will see from the next slide that every other day is so much effective because the half-life long is up to 48 hours effectiveness, and it is a cumulative effect until it reached the plateau of good effect, like 50-60% of improvement. Nurtec is a small molecule that binds to the human CGRP receptor and antagonize its function. In this slide, I like to show you that migraine, whether there is aura or no aura, most likely triggered by an input coming through our senses. We are connected with each other through our senses, from vision, from smell, from taste, from touch, even the air changing hot or the weather or humidity. So all this information, it reaches to the central nervous system. It reaches to the thalamic area. Then when it reaches there, there is electrical transmission and chemical transmission. When it reaches to the neuron, to transfer the message from one neuron to the other, we have to pass through this chemical neurotransmitter chemical transformation. In this area is the role of the CGRP specifically. In the migraine people who are more sensitive to the sensory input, this CGRP, it rises abruptly and to very high level. And that is the meaning that the patients are more sensitive. Those migraine people are more sensitive to any input. I feel that their brain make more data analysis of the information that they are getting. That's why we find abrupt rise and very high rise to the CGRP, and those medications, they just modify, they control, they normalize the rise of this chemical, and that's why they control all the wave of the migraine attack. And that's why, as I said, we cannot find overuse, and we will find very good effect in the people who are really responding to this medication with all the complaint around the attack. For acute use of Nurtec provide an efficacious, it's really so much effective. I want to tell you a story of my patient. One of my patients, she had migraine attack that is extremely associated with muscle spasm and the cramp, to the extent that she went to many orthopedics. She thought that she has joint problem, and she was suspected to have rheumatoid arthritis. And all her serum tests were normal and negative. And when she came to my clinic, I told her that you have migraine because she has episodic pattern that starts with headache, but from the severity of the muscle cramp, she forget about her headache and she was concentrating about the muscle pain. Believe me, this patient responded nicely with the rimegeptan, including the muscle spasm that really causing tension on her joint. She improved from all aspects, even from the psychological aspect that may be related to pain or related to the noxious stimulation of the migraine attack. She had a great improvement, and I don't forget this patient. So I want you to try to see all the shadow, including nausea, of course, photophobia and phonophobia, and see in your experience how much people really improve from those magic effect of the new medication anti-CGRP. However, it is really effective, fast-acting treatment option with freedom from pain and of disability, freedom also the most bothersome symptom, as I said, in short period of time, 1 or 2 hours. Patient treated with Nurtec with rimegeptan as PRN for the acute medication. We found like in 2 hours they have 50% improvement, so they can stay at work. They don't need, maybe we tell them all the time, try to reduce the light around you, block your ear. I advise my patient to bring ear block for the divers and use it because it's really helpful so much for the more benefit and effect from all type of medication, including the rimegeptan. Like 1 hour, they can go back to their effectiveness at work. They don't need really to go home or to rush to the emergency room. And that's from my experience. And they are maintaining good effect for the next 10 hours. They can go home and sleep. It will reduce at the end of the second day, but they still feel improved, at least by 50% of the patient, they really still improved. Primary endpoint pain freedom from the most bothering symptom at 2 hours, as you see here, pain freedom. Placebo is green, Nurtec is blue. Always Nurtec is higher, as you see. And here they said that placebo, it was used other. It's not no medication, it's other type of pain medication, but it was not informed. They didn't tell the patient what are the other medications. Still, Nurtec is having a good improvement. In the secondary endpoint, the pain relief and ability to function normally, and here is the disability associating the pain of the migraine. Again, in the early action 6 in the first hour, pain relief was 36.8%, ability to function almost normally 22%, which is very good. It takes the patient from the worst type of headache and disability to the moderate. And going to the moderate, the patient will be able at least to continue functioning at home, at work, or as a student in the school or university. 2 hour effect, it will improve, increase again in the second hour up to 59%. Unlike triptan, it gives you more improvement in the first and second hour. Here in the CGRP medication, the improvement will increase in the second hour. The third hour, you will find better improvement. Then from the second hour to 48 hours, there will be 42% improvement and 26-30% ability to function normally. Ability to function normally is the disability that is associated with migraine. Even when the pain reduces, the patient will remain in fogginess, in low energy, type of euphoria that he cannot really go back to work again. This will improve with the pain reduction. People can still keep going at work without losing their job and having a lot of absence from work. This is very important slide. Nurtec is shown to be effective in the patient with a history of triptan failure. Actually, the current algorithm that they want us to start all the time with triptan, try non-steroidal, try triptan. Then if triptan fail, you can go to the new generation of anti-CGRP. Actually, I'm trying to do that in most of the cases, except not only triptan failure, if there is contraindication. I would not try any more triptan if there is any suspected contraindication or any patient who is having vascular risk factor. If he is heavy smoker, they have diabetes or a strong family history of diabetes and hypertension, or any history of suspected coronary artery disease, I consider is a contraindication and I go directly to the safest medication. Improved freedom from pain and bothering symptom is observed in patients treated with Nurtec, regardless of triptan status. They found that the people who took triptan, they have, we have a patient who didn't take triptan. They found effectiveness from Nurtec. Patient didn't take before, I mean, it was the first time they tried triptans. They still found better and higher effectiveness of the rimegeptan, the Nurtec, while the patient who take triptan on the long run, they lose the effectiveness of triptan and they find much better effectiveness of Nurtec. And I think there is two factors because of no side effect from Nurtec and triptans, it loses its effectiveness with the time because of the multiplicity of the side effects and also because of the mechanism of action that is only correlated with vasoconstriction. So this first one is naive patient who take triptan and try Nurtec. The second bars here, people who currently taking triptan at times, they try to take Nurtec after triptan, they find also more effectiveness. And if you look in the last bar here, the patient who failed two type of triptans, they are really the best people who improve on Nurtec. So whenever you have people who tried one of the triptans or the second one, don't bother to give them another brand, just move directly to Nurtec. It is 100% justified and they will find big difference and they will really appreciate that medication. So data tell us that 64 of subjects had no history of triptan treatment failure. As I said, this group included the triptan naive, as I explained, and patients using triptan at the same time of study enrollment. The remaining 35% has a history of treatment failure with one, and then one or more than one triptan, two triptan. For the recommendation for the acute treatment that all patients with confirmed diagnosis of migraine, of course, it's not being used for cluster headache or trigeminal neuralgia. So we have to confirm that this patient is not neuralgia, it is a migraine headache. Because I notice sometimes there is failure because every time I find failure, I revise my history. I revise the patient history. I listen to him again carefully to see the episode, how it starts, how it ends, to confirm that it is migraine. It is very important to confirm that it is migraine. For mild to moderate attack, we usually start with non-steroidal anti-inflammatory, non-opioid analgesic, acetaminophen, or caffeinated analgesic. And I usually tell the patient to take dark chocolate. They really like it. And they found a benefit from that. I always make sure that they are drinking enough water, they are avoiding the light that bother them. And this is the mild to moderate attack. We need to get rid from the triggering factor. If they are in crowded area inside the shopping mall, go to a silent area, go away from the kids playing area. It's really effective. I always avoid opioid medication. It take them and especially the benzodiazepine. Also, I don't like it. It take the patient quickly to type of addiction or dependence. In moderate to severe attack or mild moderate attack that they respond poorly to non-specific therapy, use migraine specified agent, triptan. Now we go to triptans, of course. Then we go criteria for initiating triptans, ditan, or neuromodulator. There is another type of medication, ditan also. Of course, this medication should be written by licensed physician who confirm diagnosis and confirm that he used the right medication in the right time, and patient above 18 years old because it is not yet studied and approved for below 18 of age, and with confirmation of the diagnosis with or without aura. Either contraindication or inability to tolerate triptan, as we said, or inadequate response to 2 or more oral triptan. I really rarely go to 2 types of triptans, as for myself in my experience. However, this is the way we are reaching to triptans in the acute management of migraine. Now in acute therapy, reduced monthly migraine day, there is a good long study. It gives us good information. 60% of acute patients achieved 50% reduction in migraine monthly attack. over 1 year time. Imagine it is over 1 year time. They are given the Nurtec only PRN per need, and they need it maybe once weekly, or every 2 weeks or every month, at least one tablet, and they have reaching 50% reduction, about 60 or 70% of the patient all the year, which is really for the episodic migraine. I think it's really very good achievement. And for us, who we are working, as I said before, the era of the anti-CGRP, it's a magic effect. The preventive benefit associated with repeated acute treatment is not correlated to increased pill use over the time. That's what we said. There is no ability to overuse Giptan, as I said, related to the mechanism and of action and for the long life duration and the lack of side effect. And it is fast onset of action and long duration of action. So there is no need to repeat the medication again and again. So less than 1 tablet used per monthly attack support a sustained response and suggest a preventive benefit. Here, already over 100,000, I think it's more now, that has been using Nurtec. They made across 1,800 patients over a year. Now Nurtec in our area is used more in Gulf area. It's launched very much early. We have very good experience with this medication since its launch, and I think the number are more than this was mentioned here. In the phase 2-3 randomized double-blind trial, yeah, we are talking now about for preventive medication, how is our experience to use it as for prevention now. So there is a study also, they study it for a long time, and they give us a good idea about the stability of the effect. It's a placebo-controlled study. A preventive treatment with Nurtec for patients with migraine result in a significant greater reduction in the migraine monthly attacks compared with placebo. As you see, we have a difference between the green and the blue. The majority of patients in the study had migraine without aura with an average of 10 during 4 weeks time. Of course, in a month, patient can have 15 attack, maximum 20. Reduction 10 times is really a very good achievement. Now, around half of the patient taking Nurtec as preventive medication achieve more than 50% reduction of the number of moderate to severe migraine days per month after just 12 weeks of treatment. Improvement in the number of migraine days per month were observed in the group of patients treated with 75% milligram every other day versus placebo. Reduction. I want to say one comment from my experience. We are saying that we have more than 50% of people, they got reduction more than 50% of their pain. But what I noticed that some of the patients, they have more respond I mean, if we are talking about personalized management of migraine, which we see and which we do really in our life, some of patients, they reach 70 and 80% improvement. But when we introduce a new medication to those patients, we should not tell them that they will reach the 100 effect improvement. Even if it is a specific medication of migraine, we don't have definitely more than 80% improvement of any one of the patient. So if they got a severe attack while taking such good medication, they will become depressed. I have another attack. Of course, we have to prepare our patient that they will keep having attacks, but we should tell them that the reduction of attack will be on 3 axes. The frequency of the attack will be, of course, much less, the severity of the attack and the duration of the attack. With preventive medication, we want to teach the patient how to observe their improvement, because when they come for follow-up, they remember only the last and the worst attack, and they give description without remembering that the improvement is coming on the 3 axes that I described. So 50% reduction is a very good for me, as I know. I really feel happy when I teach the patient how to observe their improvement in the moderate or severe migraine days per month in the week 9 through 12 weeks. Regular every other day dosing of Nurtec is effective as preventive medication and proven reduction in migraine attack frequency and positive impact on disability, which I stress, which I see. And really, I really appreciate for my patient, enabling them to plan their activity, to enjoy their life, and for their duties as well. In the preventive setting, in the long-term data of repeated treatment of Nurtec, there is maintenance of the effect. And this is the importance, because in the injectable form, which is really very good also, which I appreciate and use, but we notice that some patients, they have end of dose relapsing migraine headache. So some of the medication is every month. Some of the patients, they have increasing headache in the last week before the next injection. They call us, can we take the injection earlier, like 1 week? So those patients are candidate of moving to the oral form because every other day, all over the time, it gives us stability of the effect. We don't have much fluctuation. This is very which I noticed actually. Then we need to talk about. I want to comment about using rimegeptan as a preventive medication and as PRN also. It is also very safe. We can use it every other day, and we can use more 3 tablets all over the month for the acute and severe attacks, mainly and actually, especially for the people who are not accepted to take the triptan, who have a contraindication of triptan. Here they are comparing the effect of irinumab and galcanezumab, the Emgality and the Aimovig, and they follow over 12 weeks time, and they found that the effect is comparable. Now we are keeping the Nurtec for the moderately severe migraine attack. However, it is comparable effect, as you see. And we want to say that additional beneficial characteristic of Nurtec is convenient administration of the oral, and there is no need to keep the injection in the fridge and to have any problem or difficulty in getting from the pharmacy, going home and take the injection. This is only tablet. You can keep it with you in the room air temperature. It has very good it is very well tolerated, and a short half-life of about 11 hours, and no attenuation effect until at the end of the month. This slide, we are talking about comparison again between Nurtec and the placebo in the acute and in the long-term safety study. It is very safe medication. They say that we have 2% effect on severe hepatic-related adverse effect. Actually, we didn't see it at all, and it needs no modulation of the dose or any change of the dose for the mild to moderate hepatic impairment, and it has also no effect at all on the kidney or on the cerebrovascular circulation. The only thing that it is not studied and not accepted during pregnancy or breastfeeding. In the preventive study, as you see, the adverse effect is very low. We are studying 6,000 patients. There is only 40 patients only. They found some Nurtec side effect of those. Sorry, the number is 370 40 of them, they have some side effects. Most of the side effects were like nausea, mild abdominal pain, feeling little bit reflux, and also those symptoms can be associating with migraine. It was noted in some of the patients that it is a little bit increasing. However, in the first 2 hours, after the 2 hours, is also this side effect will reduce. Serious side effect with a preventive strategy that is every other day is 0, as you see, because the patient is taking every other day. It has no side effect, so whatever. Long-term use of Nurtec is favorable, very well tolerated, either as acute or preventive management of migraine. 2% of the patient discontinued due to adverse effect through 52 weeks, which is very low number, and Nurtec half-life supported sustained efficacy. I think people who stop it, maybe they are using as PRN, more frequent dosing, but depending on the preventive dose of every other day will enable even less drop number. Nurtec half-life supports sustained efficacy as acute treatment and enable immediate cessation when used in the preventative setting. Here, there are some safety advice. Of course, Nurtec has very little drug-drug interaction. Only doctors has to know that it has interaction with CYP3A inhibitor, some of the medication. There is some interaction. Actually, this interaction is not causing a reduction of the effectiveness of the medication. However, we want to know what are the medications that being used with this Nurtec. There are no adequate data on the development risk associated with the use of Nurtec in pregnancy, as I said. In hepatic impairment, it does not need any adjustment of the dose. The most common adverse reaction, as I said, is nausea, abdominal pain, little dyspepsia. We can give the patient proton pump inhibitor or antiemetic, which I really use. And antiemetic is known to improve the migraine attack. It is used in the combination of the acute and severe attack and in status migrainous. It reduces the side effect, which I advise actually. It's easy to use, easy to hold and carry in the bag. International cross-sectional survey conducted in 2009 reported that vascular disease risk factor were observed in 41% of the patients with chronic migraine and 33% with patients with episodic migraine. Of course, and we all know that migraine because it's a vascular headache, it carry a risk of affecting circulation. So triptan are contraindication with cardiac risk factor, and we are having now a very good option for the acute and preventive management. In patient receiving acute treatment, here we are talking about a very important point. I think this is the last important slide. The Migraine Disability MIDAS scale, Migraine Disability Assessment Test. We have a little questionnaire. We are studying the effect of migraine on our patient from the how much they are absent from work and how much they are staying at work, but they are not effective. So we have two concepts, absenteeism and presenteeism. Patient who has migraine, they are frequently absent from work. They are missing the work or activity, or if the housewife doing her daily duty toward her kids, and if at work they have a lot of sick leave and it is affecting their budget, it's causing another burden and anxiety on their ability to keep going at work and keep improving also at work. And presenteeism is even worse because they stay in the work, because they have moderate pain, but they are not able to concentrate. They have fatigue, fogginess, difficulty in concentration and reading well. They to understand what they are reading and to say properly what they feel at what is their opinion at work. So people, they become little bit foggy during migraine attack. So we need to assess the patient regarding this disability. That how much they are absent from work and how much they are still at home or any other where, but they cannot really be effective as they are not also not enjoying the work and they cannot attend even social activities. This is my dance scale. My dance scale above, I think above 30, it is severe disability. Between 11 to 20 is moderate disability, below 11 is mild disability. So here we are studying the effect of Nurtec on the disability. As you see in the first graph, Midas from baseline by 52 weeks, we have very good reduction, -12 in the Midas scale, which is very good. And then it maintains its effectiveness on the disability of the people. So disability is not only related to pain, it is another factor that I think it carry more risk on the life of the patient. And as we study how much they are spending money on their illness and how much they are losing money from their illness. So there is a very good improvement on Midas scale. And now we are assessing our patient with migraine diary and the Midas scale to see how much is effective and to show the patient how to count their improvement and how to not to get worried or anxious if they got another attack at any time, but they look at the general result of the management. There is, of course, we say that more patients prefer Nurtec on both acute and preventive medication. As we see here, this colored slide is really nice to show that in the acute management, in the green area, 45% of the patient, they prefer the Nurtec on other modalities, while in the preventive, actually, preventive management of migraine, like 60%, they prefer Nurtec on other modality. And this was assessed through questionnaire from 514 migraine patients and revealed that more than 60% of them, they prefer oral route of administration for the causes that we previously mentioned. Again, here, the being absent from work or present but ineffective, there is 44% of the patients, they found improved productivity 11 days per month from the former assessment before starting this treatment. So migraine-related absenteeism and Midas disability grade are associated with total health care and pharmaceutical cost. Patients with migraine-related lost time incur significant higher medical cost. As I said before, patients treated by specialized incur higher cost. Here are the bar that is being studied. So this is the end of my talk, and I'm ready for any question.
Thank you very much, Dr. Manal Faham. It has been a pleasure to have you with us tonight and to listen to your experience with rimegepant in managing migraine in your practice. I have a few questions, so I will start first with a question that I've already asked Dr. Pizzetti, which is the migraine calendar or the headache calendar. Is this something that you use in your own practice? And do you find that your patients are accepting to the idea?
100%, 100%. I use migraine diary and I advise all physicians to use it and to teach the patient how much it is important, because if you don't know the baseline of your patient, now medicine is personalized, neurology is personalized. Every migraine patient is a different story.
True.
And even if the mother is migraine and her kids is migraine, they have not the same story, for sure.
True. True.
Regarding the headache severity, the frequency, the triggering factor, even the food, you know, relation with the food, relation with the society, they are different. So you need to teach the patient to know themselves at the beginning.
True.
Except if the patient come to you with definite diagnosis. I 100% depend on the migraine diary, and for the ladies, the relation of menstruation. It's really so much effective tool of
Okay.
knowing the pre and post, and to appreciate how much they really improved with least side effects.
So I thank you very much, because I had that question for Dr. Pizzetti, and I thought maybe it's not in the same context of medication overuse headache, but you've just talked about it, and that is food and migraine. In your
Yeah.
experience, food and migraine, what do we know? What is your advice? How do you manage this conversation with your patients?
Yeah. Look, actually, I am one of the doctors who stress a lot about finding triggering factors, and I do find. And my percentage in my practice, I notice that higher than the percentage of other physicians, maybe because I give long time discussing that issue with my patient. And I found really clear correlation. I have many ladies who are convinced finally to stop all the cheese from their food. Even little parmesan, they found difference. I really found difference. There is big difference. They should know that putting some cheese on the pizza is a cheese. Putting little cheese on they found difference. And they have relief. If you find relief from stopping one of the food, like 10%, it's a good achievement, you know. I tell the patient, you find your own limitation. I find that there is correlation with junk food, correlation with additive, correlation with the artificial sugar. I found correlation, of course, everybody knows, with the soft drink that has a lot of caffeine. I don't want to say the name of a brand, but you know that they call
Energy
the
drinks
D-power.
also, not
Yeah,
only
exactly.
carbonated,
Yeah.
even
It
energy
triggers.
drinks.
Yeah, of course. Energy drink. It give a trigger actually. So
Yes.
I give time to teach the patient. You know, you want at the end to have the most success rate with the least side effect. So if you have 30% of the patient, they found their own trigger, they will be happy and you will be happy. You know, it's really, I found it so much important actually. And I teach my patients how to try to enjoy making their food with their own hands, you know, because you spend time smelling the food, cooking the food, and knowing what do you like, what you don't like, and avoiding artificial food.
Absolutely. And I know that there were some studies saying a higher protein diet is always better than a high carbohydrate or a high sugar
Yeah,
diet.
yeah,
So you talked about sugar in general, artificial sweeteners even worse. But in
yeah,
general, the higher the protein in diet, the
yeah,
less likely we are to trigger, because then there are less variations in blood sugar as well. And that
yeah.
might cause, hypoglycemia or hyperglycemia. And so this might be a trigger.
Let me give you a little comment on this regard, if you allow me, please. I noticed that migraine people has to be moderate in everything. They
Yes.
should be moderate in too much sweet, moderate in too much citrus food, moderate in too much spicy food. They have to be moderate, actually, because if they give a high level of sugar, they may trigger migraine also, as you said exactly. So moderate in their life, you know, moderate in overworking, moderate in not sleeping like that. So I prefer for them to find out always to be moderate in the food also. The variety of food, the type of food, like that.
And we had the earlier question about the parent who was worried that their child might have migraine and they don't want to believe it. What is your advice to the
Oh, yeah, of course. Actually, now I learned over the last 10 years of my life that whenever I find a mother, I immediately ask her, which child from your kids is similar to you, or you think he may have migraine? Look for your kids. I teach her ahead. I do that in my clinic. And many of them, they tell me, oh, I have one. Maybe he is like me. I will observe him.
Mhm.
I will look for his pattern when he become impulsive. You know, children, they don't tell you I have headache. He will just cry. he
But
becomes
abdominal
nauseated.
also, I mean, in children, we
Abdominal,
see
I
more
want to tell you.
abdominal symptoms. And a lot of
Yeah,
times I mean, I myself is a mother. How many times do you have a child that says, my tummy hurts, and then they cannot take
yeah,
the light, and they lie down and they say, my headache hurts,
exactly.
I have a headache. And you think it's okay, they're just tired, or they're coming down with
Yeah,
a cold, but most of the time that is migraine. And we know migraine is 10% of children might experience migraine. In
yeah,
adulthood, less men, and it's more boys and girls. So also
yeah,
that's something that might lead to the delay in the diagnosis, but also diagnosis
exactly.
is very important. We need to know what is happening so that we know how to manage it. So
Exactly.
possibly this leads me to my next question that I got from one of our followers or our viewers tonight, and that is, what would be the best treatment for pediatric migraine connected with dizziness and attention problems, I think is the question. I think there's
Yeah,
too many questions there. So let's focus on pediatric migraine in your practice. Do you see children, and do you treat children? And what would
yeah.
you do?
I see children above 7 years of age, and as I told you, I always draw the attention of the parents about their kids. I think for children, the most important is to know them, to know the pattern of their attack. As you said, many of them, they do have migraine, abdominal migraine. I have one lady, she is migrainous, and her kid had abdominal pain attack, and she saw many doctors, she did many endoscopies, and every time I tell her, you have to suspect abdominal migraine, because abdominal migraine, it has relation with light and sound and the stress. When they go to school, somebody is shouting, a stressful condition, they can have migraine attack. Of course, children, they can have migraine because migraine is genetic. Migraine is coming with the personality since birth. It appears with the time. So for the treatment, I spend long time. I teach the family how to know what are the triggering factor. Believe me, in kids, you can find it more than in adults.
Yes, I think
Easily, you
they're
can
able.
catch it.
I find my patients that are children are
Yeah.
more accepting, they're more aware, they're still not,
Yes.
they don't have preconceptions. And that makes
Yeah.
it easier for them to,
Exactly.
if you
Exactly.
educate them, if you tell them,
Yeah.
then
Yeah.
they
Yeah.
also stick.
They obey, yeah, because you respect them, Sometimes family that they don't believe. Do my kid have headache? Of course he has head. He can have headache so long he has head already. So when you talk to those children, they feel that they are really important and you are listening to them, you believe them, and you give them clear instruction. They follow. They really follow. They drink enough water. They stick to the schedule of sleeping in the night and the switching off the mobile. If you give them the attention and you respect that, they will really follow. Though I try to tell them to drink enough water. I go to magnesium with kids because it's a safe medication. We don't have
Yes.
a lot of options. I give the children actually, and I tell them to drink water. I give them sometimes vitamin B2, some of them maybe placebo effect. I'm not sure, but magnesium, I think it makes difference. Then Panadol, PRN, and I tell them to take dark chocolate at the beginning of migraine attack with the paracetamol. They really enjoy it, and they stop eating the chocolate that is not the dark one, yani, not the healthy chocolate. They really stop it, and they keep the chocolate for the acute attack, and I found really good improvement. There are very few medication, but from the age of 10 years, we can give bedranol, I mean the propranolol, the beta blocker, if the patient is not asthmatic and has no side effect. Very small dose can give effect. Pizotifene is a very good drug. I don't know why it's not in the market. It's very good for kids. I really like it.
I know that in Danish Headache Center, where I spend a lot of time, of while here in Denmark, they use also candesartan, which is also not indicated in the prevention of migraine in children, but is used for cardiovascular, and it seems to actually work very well.
Good.
At a lower dose, you can start at a lower dose, titrate very
Yes.
slowly, and it doesn't
Yeah.
cause dizziness, no contraindication with asthma. So we have that experience here. We're almost at time. I'm going to give you one last question that I think is very important for and I have a lot of questions. There's not enough time, and I thank everybody who has put their questions there. And I'm really sorry we can't get to all these questions. But one question is around oral dissolving tablet. Nurtec is an oral dissolving tablet. Do you give it orally as well, or do you use it as an oral dissolving tablet? And what's the difference? Why would you use it as an ODT?
You just put it under the tongue. Put it under the tongue and it dissolves in a few seconds. It's really very nice. People, they are, you know, those type of medication are magic. They change our life as a doctors. And this Nurtec is really very good and very easy. There's no test, no bad test. It takes very short time to dissolve. If some even 18 years old, they don't like to swallow even big tablet, you know, if big tablet like calcium, they don't like it. It's small and thin, and it dissolves very easily and very quickly, and you put it in your bag, in your pocket.
Yes.
So yeah, I tell them, put it under your tongue, it will dissolve. It's really very easy.
Well, as a pharmacist, I would add, and I always wear the pharmacist hat. Remember that one of the most common symptoms of migraine is nausea and vomiting.
Yes.
So an oral dissolving tablet means that if you have put it under the tongue or inside the mouth, because it can be even dissolved around the mouth.
Anywhere,
If they throw up, you haven't lost the medication.
Exactly. It is because absorbed directly.
Exactly. So I really like the oral dissolving tablets. And even with the older formulations of other medications, I found that my patients preferred them because nausea is very bad with migraine. And sometimes patients wait for too long until they take their medication. So they're almost going to throw up and they take it. And then they throw up a very expensive medication. If they throw up, you've wasted it and you can't take another one. So what do you do? Do you take another one? Anyway, I can't say thank you enough, Dr. Manal Faham from Dubai. We really enjoyed talking to you today and all the explanation you gave us. I would like to thank again the Association of Migraine Disorders in the US for facilitating the transfer of science from the rest of the world and linking our local and our national experts with international experts from around the world. IVPN, this is the 10th migraine masterclass, and it's almost been a year. Everybody who's joined us today has been wonderful in the level of questions, and you're following us. We're going to have our 11th event on the 11th of November. I would like to thank 3 people that are in the background that I have not done this before, but I owe them a big, big thank you. We have Dr. Hussam Salamat from Jordan, who has been a big force in making sure that we are always top in terms of getting these master classes working perfectly, and all the support that we get from Dr. Hussam. Dr. Maya, this was Maya Zainuddin from Beirut. This has been her idea to start with, and she has done a great job in making sure that we are continuing to bring experts to the region, and anybody who would like to get this education on migraine. And we are very thankful. Last but not least, I have Kylie Petraka. And Kylie Petraka is from the US. She's from the Association of Migraine Disorders. And if you see all these comments in the chat telling you where else can you get information, that is Kylie Petraka behind the scenes. And of course, most important, I thank you again, our audience, for being great and for continuing to learn to bring better treatment options to your patients. Thank you very much, and we will see you in November. Again, Dr. Manal Faham, thank you very much for joining us today.
Thank you.
Thank you very much.